First off, thank you so much for inviting me here to talk about our ECMO experience. We're really excited about the program. We're excited about what we've achieved over the last 2 years. I know with certainty that there are patients that have gone home and are completely functional that would have otherwise died without this unique therapy that St. Luke's offers. So where do we start? When I think about how the program got started, I think about our first patient, Ted Hodges. And a lot of you might recall this story, but I'm just going to give you a little recap. Ted was home for summer vacation from Notre Dame. His hometown is Salina, Kansas. He had an acute viral infection that caused him to have severe heart failure. He was airlifted to St. Luke's Hospital, and shortly after he arrived here, he suffered a cardiac arrest. While undergoing CPR for 51 minutes, Dr. Borkan expertly placed one arterial cannula, a cannula in a major artery, and one cannula in a major vein that allowed him or us to restore oxygen delivery and maintain his life. Shortly thereafter, he was transferred down to the CVICU, where we cooled him for 24 hours. After that period, we slowly rewarmed him. He woke up, he followed commands, and was completely neurologically intact. Approximately a week later, Dr. Borkan placed mechanical devices to assist his heart. And this was June 5th that he came in 2 years ago, and then on September 15th of that year, he received a heart transplant. Really a remarkable story. Since then, he returned to Notre Dame. He helped lead Notre Dame to the 2000 NCAA fencing championship. He graduated from Notre Dame in May. And he gave us the enthusiasm to make this program successful. So what is ECMO? Really, it's support of the heart and or lung function with a mechanical device, which really restores oxygen delivery. That's what it does, in a nutshell. It's temporary. It's not for long-term support. Sometimes the extremes of managing a severely ill patient with lung injury or heart injury sometimes causes more damage. Even though you're trying to help, by helping, sometimes you're hurting those organs. And it really sustains life while you can bridge to a decision. You can take a deep breath. Where do we go from here? Await organ recovery. That can happen. Or if the organ doesn't recover, potential transplantation. What are the indications? Acute, severe cardiac or pulmonary failure that's unresponsive to optimal management with expected recovery or potential for organ replacement. The complications are fairly significant with this therapy. Therefore, the patient has to be fairly severely ill and a high expected risk of death. And we want to make sure that we're optimally managing them in other ways. Are they sick enough to deserve this support? So what is ECMO? Basically, what it is we're draining blood through a cannula, out a vein, through a pump, then through an oxygenator, which oxygenates the blood, and then returns that oxygenated blood back into the body. And we can provide flows up to 5 liters per minute. This little console here is going to represent the pump and the oxygenator. So there's basically 2 forms of ECMO. The first form is VA ECMO, venous arterial ECMO. And really what that is we're taking blood out of the venous side of the body, taking it through our pump and oxygenator, and returning the blood back to an artery. This sort of support provides for cardiac and respiratory support. The other kind of ECMO is called veno-veno ECMO. And with this type, we're draining blood out of the venous side through our pump and oxygenator. The oxygenated blood then is returned back to the venous system, and the patient's heart pumps the blood throughout the body. So with this type of support, you need a functional heart, and this support only provides for pulmonary failure, for lung support. So a little historical perspective. In 1971 was the first use of successful ECMO in an adult patient, actually in any patient. This was a young 24-year-old that drove his motorcycle off of a bridge, suffered multiple traumatic injuries, and had what we call acute respiratory distress syndrome from that injury. He was going to die without any support, so they brought this experimental device in. Here is that little oxygenator that I showed you before, but older technology. This was called the Bramson lung. This patient was on support for 75 hours, and he survived. In 1975 was the first use of ECMO in a neonate. This was a baby born from a Mexican immigrant. She had what we call meconium aspiration. She was otherwise healthy, but she had severe lung injury and was going to die without further support. So they brought the machine in. At that point in time, you didn't have to have approval to do all this thing. You could just do it. And they put her on ECMO. And here you can see the ECMO cannula coming into her neck. So she was on support for around 72 hours. And I had the opportunity to meet her 2 years ago at an ECMO conference. So she is an adult, and she was soon to be married. They named her Esperanza, and that means hope. By the mid-'80s, ECMO was standard of care for neonatal respiratory failure. There were 5 studies at that time that proved a survival benefit. So this chart here is from what we call the ELSO registry data, Extracorporeal Life Support Organization. It's housed in Ann Arbor, Michigan, at the University of Michigan. And they keep track of all patients that go on ECMO and the data, and they accumulate data. And they've been keeping track of this since 1989. And as you can see, the majority of ECMO has been for neonatal pulmonary. What you can see, though, over the years, that the use in this population has decreased. And that's been a good thing. The reason why is because we are better at managing lung dysfunction, the invention of the oscillatory ventilator, the invention of nitric oxide, and better ICU care. But still, this population remains the majority of use of ECMO today. So what about adults? So again, this comes from the ELSO registry. And you can see that this, we're talking about adult cardiac now, that really, it hasn't been so widely used in the adult population. However, in recent years, the use has increased. The primary use for adult ECMO, cardiac ECMO, is for myocarditis, and that's what Ted had. About 80% of the cases are for myocarditis. So why has the use increased here in recent history? And I think it's all technology driven, and I'll talk about that. So here we have adult respiratory failure. Again, not commonly used. Early studies did not show a survival benefit. However, in 2009, you see a big rise in the use of ECMO for adult respiratory failure, and that is because of the H1N1 pandemic. And patients that were severely ill and had a high risk of death, so greater than 80% risk of death, went on ECMO support. And what was encouraging about that data from both Australia and the United States is that those patients had approximately a 70% survival to discharge. So again, the most severely ill patients that had a very high likelihood of dying had a 71% survival to discharge. And I think from that experience, we'll see especially ECMO increase, especially for respiratory failure. Here we have 2011, and the data is not completely in. Obviously, we have half the year to go. So what are the innovations? How has it changed? Modern technology is completely different than what we used to do. The circuits used to be very complex and cumbersome. There was a lot of circuit failures. You'd have to change out the circuit every 6 hours. The oxygenator that we used there was a high resistance through it, and it caused us to have to use different kind of pumps. We had to anticoagulate patients at a high level, and there was a high risk of bleeding and death from just bleeding. We used a lot of VA ECMO for respiratory failure, and we've learned a lesson. That's not the best form of support. VV is better for respiratory failure. The vascular access was difficult, and the physiology was complicated. So how is it different today? Well, we have a new oxygenator that's been introduced in the last 5 years. It's a polymethylpentene oxygenator that has a very low resistance. It allows us to use a low pressure pump. The circuits are coated. We don't have to use very much heparin or very much anticoagulation with these patients. We've improved our vascular access. We've learned how to transport patients on ECMO. And we've gotten better at managing patients in the ICU. So this is the new Quadrox D oxygenator. It's just this little square device. We've had patients on support for up to 21 days. And other places have had patients on support over 100 days with this oxygenator. This is the small centrifugal pump that we can use with that oxygenator. This is what the ECMO circuit looks like at the bedside. Here's the Quadrox D. Here's our pump. So blood's coming out of the patient into the pump, through the oxygenator, and back into the patient. This is an example of the circuit at a bedside of a patient in the ICU. Again, the Quadrox D pump here. For VV ECMO, this is a new cannula that's been introduced. It allows one stick in the right IJ, and we can both remove blood and circulate blood back into the body through this one cannula. That avoids cannulas in the groin, and it allows potentially patients to get up out of bed. This is an example of a patient that is awaiting a lung transplant. She has this Avalon cannula in her neck. You can see that there's no ventilator. You don't need a ventilator when a patient's on ECMO. And she looks pretty healthy, doesn't she? So I'm just going to talk about a few patient examples that we've had. You may or may not have heard about this story. This was a story of a 30-year-old construction worker in Raymore, Missouri. He was going down the sewer to inspect for sewer damage from this construction zone that was nearby. Somehow his harness released, and he was swept from this Foxwood Drive about a mile or so to the 15th green of Creekmore Golf Course. There was a filter in the sewer system, and that prevented him from going into this lake. It was a 27-inch pipe. When they pulled him out, he was completely covered in fecal material. He was talking at that point. He was life-flighted to St. Luke's. He arrived in the CVICU. He was purple, and we could not oxygenate him. We couldn't deliver oxygen. Within an hour, we got him on VV ECMO. He was on for 6 days, and he came into the hospital October 12th, and by Halloween, he was trick-or-treating with his 3 daughters. And I'm convinced he would have died without this support. This is another patient that came from St. Joseph Hospital. Her name's Terry Blake. The physician there called me and said, we have a very sick patient. She came in yesterday. She had a severe pneumonia, and he didn't expect her to live through the night. In fact, he didn't expect her to even survive the transport over here. And he thought, what do we have to lose? He had heard that we could do this therapy. He thought, you know, we don't have anything to lose. Let's get her over. So we accepted her. Within an hour of her coming to the CVICU, we put her on VV ECMO. She was on support for 21 days. And believe me, I thought this gal would not have lived through the night. It's true. And there she is. Now she's at home living a productive life. This is a picture of her after this ordeal with her grandchild. This is another one of our patients that we had from Rogers, Arkansas. He had a viral pneumonia. He wasn't getting better there, and they had somehow heard about our program. The family was researching, and they had heard about our program. So he was airlifted to St. Luke's. He was on support for 14 days, and he is doing well. Ironically enough, he came into the unit today, and he looks incredible. He is back to work, working 40-hour work week, completely functional. So who does ECMO? So this is a map that illustrates this. There's about 188 ECMO centers internationally, about 130 in the United States. So we are unique in that we are basically one of 2 other centers that do adult-only ECMO. Let's zoom in a little bit. Here we have the yellow here right behind us. That's Children's Mercy. They do neonatal and pediatric ECMO. Again, we're the only adult center anywhere close. So we have kind of tried to advertise this. We've worked on sending out flyers. This is an example of one of the flyers that went out. It went out 200-mile radius to all the hospitals, to the ER physicians, pulmonologists, cardiac surgeons, and cardiologists, to kind of describe what ECMO is and who might be eligible for ECMO, and really a number here to call us if we can help or we can provide support. We eventually want to be able to go out, cannulate patients, especially for VV, and bring them back to our hospital. A lot of times, patients are so sick by the time you get the call that physicians are hesitant to put them in an ambulance and transport them. And unfortunately, a lot of times they just end up dying where they are. And that happened a fair amount with the H1N1 pandemic in Kansas City. So how does our process work? If somebody needs ECMO, they call this number. It's the ECMO nurse. She obtains some important information, but most important, the physician contact number. And the ECMO nurse calls the intensivist in the CVICU. The intensivist then calls that physician right back and decides if we need to execute the ECMO team. If so, the ECMO nurse facilitates this. She calls in the ECMO team, which at that point consists of the intensivist, the cardiac surgeon, cardiac anesthesiologist, and the perfusionist. If not, we like to get the patient into the CVICU and follow them in case ECMO might be needed at a later time. The ECMO patient is cared for in the CVICU. We're unique that we have 24/7 intensivist coverage in that unit. We have the perfusionist in-house for the first 12 hours when a patient goes on support, and then they are on call 24/7. We have trained all the nurses and the respiratory therapists to be ECMO specialists. It's a 2-day course that they've undergone, and therefore they're trained to take care of that circuit. And they've done an excellent job. So what about overall patient outcomes on ECMO? Again, this comes from the ELSO registry. When we just look at adult survival, remember going back to 1989 when they first collected the data, a lot of things have changed since then. Overall survival to discharge for respiratory failure, 55%, 39% for cardiac, and 29% for what we call ECPR. And what ECPR is it's when you employ ECMO when a patient is undergoing CPR. Okay? So it's a very difficult endeavor, to say the least. How are we doing? So we've done a total of 30 patients, 30 runs. 14 have been VV ECMO, 16 VA ECMO. 2 of those have been what we call ECPR. Survival to discharge for VV ECMO has been 71%. Again, these patients were so sick that they had a very high risk of dying, and that's why they went on in the first place. Cardiac, not so well, but we recognize that. It's much more difficult. 56%, still higher than the national average. And both of our patients that we have put on during a code are outliving productive lives that no doubt would have been dead without this therapy. So, in conclusion, extracorporeal support is possible with minimal complications. We really have done very well. We've had very minor and rare complications. In fact, the nurses will tell you, I'd rather take care of a patient on ECMO than a really sick patient on the ventilator. They're just supported. We know it can be life-saving in severe heart or lung failure. Again, sometimes the therapies that you invoke, like the ventilator, can actually induce more lung injury and prevent the lung from healing. And really, what is irreversible? I think that's continuing to be defined. I think that heart and lung rest is better than extremes of management. Definitely, technology and experience has improved safety, no doubt. Technology has driven this. If what you're doing isn't working, I think you need to find an alternative solution, and that's why we need to support patients, and earlier may be better. And we have to carefully select our patients.